Start, Rabbi. There's a question first up relating, just let me bring it up here on the Slido. In the case of atrial septal defect type 1, could you give us some advice about the differences between an ASD and an atrioventricular septal defect? That's right, you're busy getting it hooked up, and an AVSD. Or let me ask a slightly different question, Rabbi. So you're looking at a four-chamber view of heart, apex up, and you see dropout in the perimembranous portion of the ventricular septum, you see dropout in the atrium primum. Tell us your approach in that situation as to how you go about working out, you're looking at a complete or a partial septal defect, how you go about it.
The question, if I understand well, is are we really able to differentiate between ASD1 as a partial AVSD and a complete AVSD?
Yeah.
At this stage, I say, I think to what I could see today, from a lateral view of the heart, there is no ventricular septal defect, but I cannot guarantee for now. Counseling is at this stage the same because I will offer you to have invasive diagnosis. In case it's at the end a kind of small AV septal defect, management after birth will not change. So best case, your child will be going without any surgery for several months. It is possible, but however, later in infancy or early childhood and so on, they may decide to have an operation. Sometimes later on after birth, in these cases, there may be a clefting of the mitral valve, which may cause some regurgitation, but we'll see this in pregnancy. My management is think over invasive procedure, let's do this, and let's have some follow-up and deliver at the center where you get a good cardiac ultrasound after birth. In general, I will try to get my diagnosis done by 22, 23 weeks, because sometimes you discover this earlier, and then in third trimester, and then we'll see.
Yep. So. And Juleni, in that scenario, when we're faced with a defect, you're on. In terms of working out on a short axis view of the heart, do you try, no, don't go overboard, Rabbi. One's enough. Your approach, Juleni, in terms of going to short axis, working out septal leaflets, partial versus complete, can you walk us through your approach from a pediatric perspective? Yeah.
What you call type 1 is the primum ASD. So a primum ASD is an atrioventricular septal defect.
Yeah.
So if you were to cut the heart in the middle, you will see there is a common AV junction, the same as you have in a complete AVSD. So a type 1 ASD is a partial form of an atrioventricular septal defect. It has less association with Down syndrome, probably about 10%, but it still has about a 10% risk. Yeah? You can have a primum ASD with 2 valves, which is usually the case, and you can have a VSD. So Rabbi referred to a cleft in the mitral valve. There is no mitral valve. The anatomy of an atrioventricular septal defect, the AV junction, is completely different from a normal mitral and a normal tricuspid valve. You have one big ring with 2 orifices, and the left valve has 3 leaflets. So it's a tri-leaflet left AV valve. So a primum ASD is a form of AVSD. The same as you can have some babies that have just a VSD, no atrial septal defect, and it can be a VSD of an AVSD type. Some people used to call it canal type defect. Again, has a strong association with Down syndrome. So there's only a question of nomenclature, but the primum ASD is a form of an AVSD.
Okay.
Next time I talk about AVSD.
Okay, we'll put it down for the next. Okay. So we'll come back to maybe septal defects in a second, but just to change tack, Fatima, if you can see that question that's come in. And in the meantime, folks, if there's anybody from the audience or online, please send your questions in. There's a roving mic. Fatima, there's a question here, assuming a case at 20 weeks of gestation with anti-row, what measurement considered first-degree AV block in that setting?
Well,
And then the second question is, and when should treatment be considered, immunological or steroids? Yeah.
well, that's a very difficult question because we don't have a good consensus. I think that maybe Julien can also comment on the treatment. In our hospital, for many years, we were following these patients. In my hospital, there's a big unit of autoimmune disorders, and we have plenty of these patients that we are following. And in the past, we were doing a scan every 2 weeks to all these patients, which was very stressful for the mothers. Now we are selecting those with higher risk, so with previous, mainly with a previous affected child or that the doctors from autoimmune disorders consider higher risk, and then in those we do scans every 2 weeks. In the other ones, we do an echocardiography at 20 weeks and then at 28, and that's it. And if we do the echocardiography, we measure this AV interval that reflects more or less what happens in the PR interval, and we measure this time, and it has to be below 15 seconds. Yeah. So if it's more than that, we start to suspect, we have to reconfirm and rescan, resuspect that then can be a first-degree AV block. And then there is the issue of whether we start with corticosteroids, and then we consult the patients, we explain the evidence, the risk. I have to say that many patients then choose to treat that. But yeah, there is discussion. I don't know, Julien, because you have already commented in your class, no?
Yes, I think, maybe the question came before, but there is, if they listen to the talk again, there is this nice paper, and I think 3 standard deviations from whatever method you're using. And in that paper, there is only method for Doppler on the left ventricular inflow, outflow, pulmonary artery, and SVC and aorta. There is another question here about if you're using a nominate vein, if the interval is going to be different. And it's bound to be different because you're further away from the heart. So that's answering the other question. So you should be at least 3 standard deviations. There's also some papers that show that sometimes you have an increase on the AV interval that's not due to the AV conduction, but to a myocardial property. So there is an increase in the isovolumetric contraction time, which means there is some myocardial abnormality, not necessarily a conduction abnormality. So most people these days do not treat a first-degree AV block. Yeah. Toronto is a center that has done a lot of work with Edgar Yagi. The best way, which unfortunately we're not doing, is to measure the level of antibodies, and that's the only way to stratify. The obstetrician saying the woman is high risk, it doesn't help. You need to know the level of antibodies, but most people do not measure that. Yep. We're trying to do that to stratify. We only start steroids if there is evidence of second or third degree AV block. First degree block, very rarely we see first degree AV block really. Okay. We measure the interval and you don't see that.
And you take cutoff 115 or 120 milliseconds?
Well, 120 we take. Yeah.
That's the average, isn't it? Yeah. So 120 is normal, average is normal.
If we come back now, coming back to septal, Ravi, this is a question, should we try to differentiate the perimembranous VSD as central or tricuspid on fetal echo as classification from 2018 JTCS? I'm not sure what that is, a question from Brazil. So the question is to differentiate a perimembranous VSD as central or subtricuspid. I'm not sure what the question means, central. I mean, I guess if you do a short axis view, you can see whether it's subtricuspid on a...
No, let's say, actually, at the end of the day, the main question is there a VSD, yes or no? That's it. Yeah. And I tell the parents, it's only choosing the delivery clinic for you, more or less, not more. So I will not spend a lot of time in saying, this is here a bit more for the inlet, because at the end of the day, you will not be changing anything in the management of pregnancy.
Yeah, I guess, yeah, a fair point. I mean,
they will have an ultrasound after birth.
Yeah. I mean, we have our classification, I guess, of it, and we have our 4 types of VSDs.
I say inlet.
And the question is, do we go the extra distance trying to work out what is the location of this VSD?
Inlet is when I see in the 4-chamber view,
Yeah.
and the perimembranous when I see in the 5-chamber view just under the. The only exception there is the one, could be like posterior, the one you see in some coarctation cases or in interruption of the aortic arc. They appear to be
Posterior
more
malalignment.
posterior than the other one. Yeah.
Yeah.
Can I
I mean, in terms of
Yeah,
working
you have-
at
yes.
Juleni, so do you look at looking at
I
that from
think-
2 o'clock
I
to
think there is
10 o'clock, whether it's
To
the-
me, there is confusion about classification.
Yeah.
There's the whole people dealing with nomenclature, but an inlet VSD can be membranous or perimembranous. It can be muscular. The definition of a perimembranous VSD is that you have fibrous continuity between the mitral, tricuspid, and aortic valve in the normal connection. So you can have an inlet VSD that's perimembranous, very commonly in trisomy 18. It's inlet and it's perimembranous. And you can have an inlet VSD that is muscular. That is, there is a bit of muscle between the mitral and tricuspid valve. So the inlet muscular doesn't have an association with chromosomal. The inlet perimembranous does.
Gillian, but when you're talking about these, you're talking about an extension of a VSD that occupies different parts of the septum.
Yes.
I mean, you stand inside a ventricle and look at the septum, you have very specific areas that represent on classification what VSDs are, right?
One is location, the other one is it perimembranous or muscular.
Yeah.
So you can have a perimembranous VSD, which is close to the mitral, tricuspid, and aortic. So there is fibrous continuity between them. This has implications for the surgeons as well as he puts the stitches in relation to the conduction system. So the two classifications. One is perimembranous, muscular, or what you call doubly committed subarterial, which doesn't have an outlet septum. So the perimembranous can be inlet, it can be outlet. Yeah. The muscular can be also outlet and can be trabecular, it can be inlet. So there are two classifications, then they cross over. So I think there's a bit of confusion perhaps.
When can we diagnose this reliably?
Which one?
Any one of these gestational age like. So this is the question. You discover them 20 weeks and you make this differentiation later on gestation because the heart is larger and you can have different projections or?
Some muscular VSD are clearly muscular, mid-muscular, apical VSD, those are muscular, trabecular, yeah? So when they are in the inlet, most of those inlets are perimembranous. But you can have, if you have a bit of muscle between the mitral and tricuspid valve, there is a posterior inferior muscular. So that's the definition of a muscular defect. So in tetralogy or fallow, most of them are perimembranous outlet.
Yes.
Yeah, in truncus, about 20% are muscular outlet.
The one on trisomy 18, they are inlet and large enough to get also in the...
It can be, then it's called a confluence
It's a
defect.
size issue. That's the point I was making, Ravi.
So what I think the confusion here is that an inlet VSD can be muscular or perimembranous. Yeah?
Yes.
An outlet VSD can be muscular or perimembranous. And then the muscular can only be muscular, really.
Yeah.
The trabecular one.
I think if we come back to it, the practicalities of it are, as a prenatal obstetrician used to say, Ravi, is you investigate the patient, you know the association with aneuploidy, and you check the rest of the heart looks normal for 4-chamber view.
Some of the small perimembranous, which you're calling perimembranous, is as you're coming up to the 5-chamber view, sometimes you don't see it very clearly on the 4-chamber, and you only see it when you come into the 5-chamber. So a lot of them are associated with chromosomal abnormalities as well.
Yeah, I think that what Julen is saying is very relevant because of that, because some people just look at a perfect 4-chamber view in transverse, they put the color and they say there is no VSD. And this does not work, no, because it can be inlet, outlet. So from that, you have to move down and up and just check the whole, no, and then see if it's close to the cross or far to the cross, and then try to classify it.
Super. There's a question here on
online. If I can give an advice, not on these things, but practical daily life. If you see a muscular VSD shunting in the middle of the heart, it's quite likely that it's the case. if you don't have associated cardiac anomalies, you may be having an artifact. So this is by sure. I have a lot of experience of referral where they show me images and it's not the case. So in case you diagnose these cases, tell the parents, it is possible that during pregnancy, these may close. I don't believe it, but you have to tell them. Otherwise, you attend VST, and then at 30 weeks, you don't see the VST anymore, and you scare them. And this is why you have to tell them this story in order to get your door out. Because after birth, you may say, yo, and then you say, congratulations, I told you it may close. Because, I know
That's
the mistake,
fantastic.
because,
Good news.
Because it happened to me several times. They have an VST seen at 18 weeks. They do an amnio. They get the second opinion at 22 weeks. I don't see anything. What should I tell? It was a false positive? Is it, it was danger of my baby. He put a needle in my belly and I would have ruptured the membranes and lose the... I said, be lucky. Close. Chromosomes are normal. So this is why think over a possibility of having false positive in your daily life, because the machines where we have a perfect image and so on are not so the one used by the middle.
So Ravi, so are you telling me?
I'm telling you, yes. Do you really believe? Sorry, I love Jolene, but do you really believe people will understand now? It's a membranous part of the inlet, which can be. It's for them important, but for us, daily life is false positive. So the majority of VSCs I see isolated, not the one with an overriding and so on, are almost always wrong diagnosis.
Just two things as a comment just to make. All the images that you showed of your muscular ventricular septal defects, the apex was at 2 o'clock, 11 o'clock, 5 o'clock, or 7 o'clock. The pediatric world don't want to look at they want to look in that transverse position. And I think we miss, if you take that point of view, that during a routine examination, if you look at the baby in a transverse with the apex at 3 o'clock or 9 o'clock, and you show your outflow tracts from there and go home, and you actually don't look at the apex in those positions, you miss these muscular ventricular septal defects. I honestly believe that. And I think your talk demonstrated. That's just a small practical point to make. But to come back to you, Ravi, on saying you don't believe that the septal defects close, are you saying you don't believe the published literature?
Yes.
Okay.
50.
But you need to publish it, Ravi.
50%, 54% are closing. So it means every second one. How many swear? Where's the Bible? How many cases have you seen closing percentage? 50%?
Well,
I must agree with Ravi. I'm afraid. I think.
Well, I'm glad.
I think a lot of the.
You can buy each other a drink afterwards.
I have a lot of referrals that come from the obstetricians these days. The machine is ultra-sensitive, but also the gains are used too high. So they get lots of bleeding, and then they come with suspected VST, and we struggle. Sometimes there is a VST. So I think to be sure there is a muscular VST, you need to see persistent color, both directions, and you sample it, and you document, you have pulse-wave dot.
Yep.
That is a clear-cut VST. If you see that at 20 weeks, the vast majority are still there at the end of the pregnancy, and they don't close before. The VST that you suspect, maybe there is one, a little bit of color here, you can't actually see it persistent, you don't see it going both ways, you can't do it. This is a possible muscular VST. It may be an artifact, it may be there's a very small one. It's not really a positive diagnosis. To be sure that you have a muscular VST, you need to see the color, both directions.
I mean, I guess the machines are getting better and better, right?
Yeah,
we're seeing
and more sensitive, and we see
sensitive.
more and more things.
Yeah. We have two questions, one from Flo and one from Reem.
Short question, how you would document such a situation with possible VST? Would
Yes.
you document it? And how?
If I see a clear-cut VST like some of Rabi has shown, I say it's a muscular VST, is unlikely to close antenatally. The majority will close in the first year of life. It does not change the risk of chromosomal abnormalities, so whatever your risk was, based on nucleotranslucence, age, whatever you had, the risk is the same. It's not zero, but it's the same. So if you're happy with the risk of 1 in 3,000, it remains the same, providing everything was okay, yeah? You do need to check everything else, yeah? occasionally you have a muscular VST and the baby has coarctation. Yeah? So you do need to do a full echo if you see a muscular VST. So if there is something that maybe there is one, maybe not, I'll explain to the family. This is the septum. Yeah? We don't look at it in that unless you're doing a 3D. If there is a big hole, you see a gap. Because what we're doing, we're sampling what Fatima said. You don't just do a 4-chamber. You do a sweep to the back and a sweep anteriorly. A lot of people say, don't miss an outlet VST, look at the vessel, but you should look back as well towards the coronary sinus in the diaphragm. So that's what I say to the patient. This is the septum. If there is a tiny hole here, I have to have the baby quiet. I have to do a sweep slowly. If the baby moves, I miss it. So if I can't show it for sure, but sometimes it suggests to say, there may be one, I'm not sure. If there is one, it's not important. It doesn't change your risks. So if it's really suspicious, I bring them back at 30 weeks or 36. But it's very important to say it's not important, yeah? An isolated muscular VST, they will close, not prenatally. If you see one, very rarely, I've seen it that I can't see later on, yeah? But by the time the child is seen, it might have closed. If you scan them in day one, it's going to be there. But we don't do scan on these babies on day one. We book them after 3 months, at least, yeah? Sometimes they're seen at 6 months, by which stage they might have closed, yeah?
And the important point about coarc, I think, is a really important point to make, because they're the babies who go home and they crash when the VST closes, and they come back in and coarc is revealed. So it's very important when you see a muscular ventricular septal defect, make sure there's no coarctation.
You check everything else. You check everything.
Yeah, because
I
the
know, but
problem
it's
is
just
that,
one of those ones that can catch you.
Because the problem is that if there is a COA and a VSD, then the discordancy at the four-chamber view. Coarctation, sorry. Yeah. So if there is a coarctation, usually the sign that we see prenatal is this discordancy, so the right dominance. But if there is a VSD, then this right discordance is not that evident, yeah, because there is blood flow going through the ventricle. So
if it's a small VSD, that doesn't apply, only if you have a large VSD.
As a tip, I removed it from my talk because I had to add the whole AVST this morning. So actually, what you should do in these cases, what I do, all VSTs I sample with the sample volume. In cases when you have coarctation, there is a high pressure on the LVOT. You will have almost more left to right shunt and very, very few right to left, because if there is an almost equal, it will return back. But if you have a more one side going from the left to the right, it means there is some pressure there. This is where I will get into the aorta. You don't see them easily on the 5-chamber view, and even on the 3-vessel view, you need to get really to the last region of the aorta or to write down for your follow-up to check again the aorta. But at the end, you are telling the parents, please check at the center. So this
I think the important thing is if you see a muscular VST, you need to make sure that that is just a muscular VST. I had a lady who I seen referred for something, there was a muscular VST. When I looked back at her report, there was a partial anomalous vein going to the right atrium.
Oh.
And then I said, well, I didn't recall her, and that baby postnatally had a sinus venosus AST. Wow. So you can have a VST with other things. So to reassure the family, you check all the pulmonary veins, you check the aorta, you check the velocities, you measure everything. You do a full echo. Yeah. To say it's isolated muscular VST, good natural history, I tell the family, if I tell you, that's my story now to them, if I tell you your baby has to have a heart abnormality, pick one. Pick a small muscular VST, because it has no consequence. But you need to make sure everything else is okay. You need to do a full fetal echo, check everything, check the velocity. You can have a muscular VST with pulmonary stenosis, so you still need to check everything before you can say it's isolated. And if it's isolated, the natural history is normal. Sure. They're normal.
And
Thanks,
going back
Jeleni.
to the false positive VSDs, I think with the new equipment in the first trimester, when you have an apical view, you can see so many apical VSDs, especially with slow flow. I used to tell the parents and bring them back, but then I stopped because they all, invariably, all of them go away. So we have to be very careful not to alarm them, especially if they're isolated, especially, of course, you need to look at the heart later on. But did it close? I don't think so, because when you see it on every one or every other, then probably it's an
I think every baby at 9 to 10 weeks is an apical muscular VSD.
higher. I'm saying 12. We don't look at
don't.
There is no, guys, there is no first semester VSD diagnosis. Please, because
There is. I'll wait for my talk tomorrow.
Many countries will terminate pregnancy for this.
No.
Please, there is no VSD in first semester, period.
I disagree.
Unless it's part of a coarctation or part interruption aortic arc, or so, but no muscular VSD.
A small muscular VSD in
or-
isolation is not a problem. Why don't we discuss it? I mean, it's important. A
Rabbi,
muscular
if
VSD
You can
is
make a
fine.
note for yourself and check again, but please don't start to terrify the patient.
No, I don't terrify patients,
You know,
Rabbi.
but
I think you can
you are
pick
an
up. You can
expert,
pick up
Sam.
muscular
You
VSDs
are-
in the first trimester.
You
I'm-
are an expert, Sam, but
Yeah.
if people go home and say, I make a diagnosis of muscular VSD, and they tell the parents, I know what they will do. They say, oh, a gap in the heart, a big hole.
A hole in the heart.
Yeah, and then they
it's
say,
very
oh, at the
dangerous.
beginning, and
No,
we are not.
I make a comment in a sense that what you can see, and it's an expression, I guess, of what the new technology is bringing. We are able to see these things. That doesn't mean that we shut it down and don't mention it. It's just that we can see these things. How we reveal information to patients is the separate argument. And terrorizing patients versus saying to patients, look, listen, there's a reason which I need to look closer at your baby's heart. You need to come back to me. Because otherwise, she's going to go to some general radiology clinic who's not going to pick up that there is a problem going on. How you deliver information is a separate issue. And I think we need to be extremely sensitive in the new world of technology. The first point to make, though, is you can pick these up in the first trimester of pregnancy, without a doubt. And I think it's going to become an issue how everybody with this technology is able to see these things. The matter is how do we deal with that information? Now, we need to be very careful. As you say, terrorize versus reassure, but make sure you see the patient back again.
Yeah.
Concern is this. I'm getting ladies who come to me in a practice where non-invasive prenatal testing costs a lot of money. We tell them, you have a VSD. They say, I want NIPT, even though my NT was normal, my first trimester anatomy scan was normal, my second trimester anatomy scan was normal. Jeleni, when, absolutely when, would you find a muscular VSD and ask somebody to go and do exome sequencing?
If it's just, you're talking about the mid-muscular VSD, an apical?
Any muscular VSD that's isolated, seen by you experts, by Rabbi, by yourself, when would you go ahead, go further and do exome sequencing?
I've never done that. I tell the patient exactly what I said before. The muscular VSD does not alter your existing risk. So you look at the risks. If she's age 40, she had a borderline risk on hormones or NT, and she, it's different, yeah? So the risk is based on previous existing screening tests, maternal age, first trimester nuclear translucency, or the biochemistry. She had an IPT, which lots of them are choosing to do privately. So if the risk was low, it remains, I don't say it's no risk, it remains low based on previous screening tests. So I don't think I ever had a patient with a muscular VSD that has gone and done an anomaly. Yeah? Can it happen with a baby with Down syndrome? Sometimes we see babies postnatal with Down syndrome with small muscular VSDs. Yeah. Muscular VSDs are common. Down syndrome is common. It can happen. But you need to look at the whole screening test. and put everything in perspective. And then if she wants, and I don't recall any patient that I had an invasive test because of just an isolated muscular VSD, with the previous screening test having been low risk.
I think it's very reassuring in a world that we have NIPT, and I think increasingly women are having it before they have their anatomy scan. And it's extremely reassuring to have that when you find your muscular VSD.
But I do send them for the fetal medicine team to see, yeah, because even if, it's likely to be isolated, but maybe 15 years ago I didn't do that. But nowadays, anything that I see, I send it to the fetal medicine for confirmation that or not that, it's an isolated problem.
Yeah. I think we might call it a close for today. Thanks very much, everybody, and we look forward to seeing you back. We'll see you tomorrow morning, 8:30.